Okay. Hi, everyone, and thank you for coming to for joining the Marfan Foundation and its divisions for our 2026 Global Virtual Conference session. This session is titled VEDS in Midlife and Beyond, Hormones, Menopause, and What We Don't Know. I'm Dr. Josephine Greener. I'm the Chief Science Officer of the Marfan Foundation. And my colleague, Ryan Rodimer, the Director of the VEDS movement, is my behind the scenes co-pilot today. Um, this session is being recorded. Before we begin, we just want to let you know to use the Zoom's Q&A feature to submit questions throughout the presentation. We'll answer as many as possible during the Q&A session at the end. The chat is also available for attendees and comments, but the questions posted there may be missed. So really, please try to use the Q&A for all questions. In the chat, if you want to tell us where you're from, please let us know. So it is my pleasure today to introduce our speakers. Dr. Melissa Russo is a member of our professional advisory board. She is also a maternal, fetal, and medicine and clinical genetics specialist and is the director of the prenatal genetics at Women's and Infants Hospital of Rhode Island. And she is an associate professor of obstetrics and gynecology at Brown University. We also have here today Dr. Kristen Matheson, who is a professor at UMass Memorial Health. And we're so delighted to have you both joining us here today and to hear your presentations. So you can begin to share your presentations.
Can you hear me now?
We can hear you, and I guess your slides are just loading.
Yep, they're coming. Okay. All right. Well, it is my pleasure to be. Can you hear me? All right.
Yes, everything's good.
It is my pleasure to talk about this. I think that women's health is a really important topic that has really not had a. Oh, we can see the notes too. There we go. Okay. Anyways, so we're going to be focusing on vascular EDS today and talking about midlife and beyond, hormones, menopause, and what we don't know, which is a lot. There's just not a lot of research right now in women's health in general. And then take that and put that on top of a rare disease, and we know almost nothing. But we're going to tell you sort of what we do know, sort of our expert opinions here, and do our best to try to help you guys with learning about just hormones and how we use them in gynecology and with menopause, and answer questions. Next slide.
Do you see the next slide?
Is it advancing?
It's advanced on my screen. Is it advanced on yours?
All right. Our objectives today was we're going to describe the physiology in perimenopause and menopause, providing light. Yep, I got it. Yes. We're going to describe the physiology of perimenopause and menopause. Yep, I can see it. Yes. Yes. Can you hear me? Or am I frozen?
I hear you.
Can you hear me?
I hear you.
Can you hear me? I'm gonna
I
not
can hear
hearing
you,
the
Melissa.
speaker clearly glitches. Okay, I'm gonna try to go out and in of the webinar.
Yeah, your audio is a little bit choppy. Maybe if you speak closer
I
to
know. I don't. I
your,
think that
okay.
my audio is very glitchy. They're saying. Can you guys hear Dr. Madison better?
I think so. Yes.
All right. So I can take a stab at
Here,
some of Dr. Russo's
Kristen, start
slides, but
the just.
clearly, are you able to
It's
hear me
all
speaking
patchy.
clearly?
Yeah, you're still patchy, Melissa.
Is mine patchy or can you hear me clearly?
I can hear you clearly.
So Melissa, do you want me to, I can, while you're
Is
logging
Dr.
off,
Madison's also choppy, or is it just me?
It's just you, Melissa.
They're saying everyone. They say yes. I know. I'm gonna.
all right. Russo is trying to get her audio set. I'll go through some of these slides with the clear understanding that I am not the board certified geneticist that Dr. Russo is, but I'm a practicing gynecologist who's been in the field for a little while. So just because I know you all have lots of sessions that you want to get to here at the conference, I'll go through these slides, and when she's able to get back on and get the audio working, she'll jump back in. So the objectives are to describe the physiology of perimenopause and menopause, to provide life phase counseling related to menopause, and discuss methods of treating symptoms of perimenopause and menopause. And I should disclose that Dr. Laura Ferraro, who works with me at UMass Chan Medical School in Worcester, Massachusetts, helped with the development of these slides, but she was seeing patients this afternoon and wasn't able to attend. So it's important to know that we try our best to use inclusive language, that while this discussion centers on women's experiences, menopause is not limited to those who identify as women. Transgender men, non-binary, and gender diverse individuals may also experience menopause. And so when appropriate, we'll use terms like people experiencing menopause alongside women. All right, sorry, trying to click through slides and do all the things. So here is where we are. Our literature search as of today, June 16th, 2026. So PubMed is one of the common search engines we'll use to find medical research that's been published. And if you look up vascular Ehlers-Danlos and menopause, you can see this. No results were found. And so there is very limited research on menopause. As we all know, that women's health research has been underfunded since the beginning of time. And then especially with rare conditions, it's even more problematic. I'm just looking. Okay, Dr. Russo is still trying to get in, so I'll continue here. Sorry, just trying to manage my slides and my phone all at the same time. It's a good thing I'm an obstetrician gynecologist and I'm used to juggling a lot of balls in the air. So this is specific to Dr. Russo, so she can answer questions related to this. But here's some of the challenges with vascular Ehlers-Danlos syndrome. General thoughts that estrogen and progesterone are bad stems from pregnancy because there's increased hormones. With this time period, we all know that pregnancy is a high risk time for cardiovascular events, but there's not a lot of data to prove that estrogen and progesterone are necessarily problematic for increasing the risk of cardiovascular events and stroke in this specific population. The other issue is this lumping together of all various symptoms, that whatever symptom you're having is automatically attributed to having VEDS. So your periods are probably heavier, or you're feeling more lethargic, or you're having hot flashes, or you're having issues with pelvic floor issues. It all gets attributed to VEDS, and it makes clinicians sometimes not intellectually curious about what else could be going on. Because, yes, people with VEDS are at increased risk of some of these gynecologic disorders because of how um, pathophysiologically it works, but you're also at risk for other things. And you just want clinicians to keep an open mind that, yes, your symptoms could be due to VEDS, but don't stop looking, or else we'll fail to find a treatment option that would work best for you. Can people still hear me? Because all I see is Melissa.
I'm so sorry.
No worries. Can people still hear me and see me?
Can you guys hear me better now?
Somebody sent up a thumbs up, so it's good. If you can hear Dr. Russo better now,
Yes.
I'll leave it over to her. Dr. Russo, I left off with the issue that clinicians lose some of their intellectual curiosity, deciding that any symptom complex somebody with VEDS has is due to VEDS, and doesn't think about the other potential causes and contributors, and might miss the opportunity for treatment. That's where I left off.
Thank you for doing that. Thank you for all
I think I've
being
heard you give your
flexible.
slides a couple of times.
Yeah, you're doing great. Yeah, and so I completely agree with that. And really, when it comes to hormones throughout the lifetime, there is a study that is starting to be done to try to get some information about this. Or I think they're just starting this study, so hopefully it will give us a little bit of information, but there's not much out there. And really, I think when a majority of people are going to the doctors, women's health is sort of at the bottom of this list, and people are thinking about your cardiovascular health, your eye health, your lung health, your whatever other things are going on, and women's health issues are sort of pushed to the bottom, and not really thought of as life threatening, and so they're not necessarily addressed. Next slide. Did it? Okay. And Dr. Madison's going to go into this, but we were focused on menopause today. But we use hormone therapy not just for birth control, but we use these therapies for things like abnormal periods or heavy periods, for really painful periods, endometriosis, and then menopause. So we're going to talk a lot more about menopause now. But there's lots of gynecological reasons why people are using hormones to help with some of their issues that they're facing related to these issues. Okay, go ahead.
All right, so
Next
let's
slide.
start with a little bit of anatomy and physiology. I know there's a little bit of a delay, so I'll try to click my slide right before I'm ready to see the next one. So we're going to start with some areas because when you understand the brain, the pituitary gland, the hypothalamus, the uterus, and the ovaries, I think this will all make a little more sense. And then you can surprise your kids when they're taking their biology classes, and whenever they're taking some of their courses in high school. Because if you're interested in menopause, I'm guessing many of you may have friends and family who have nieces, nephews, children who might be taking high school biology. So the hypothalamus it's in the brain, contains a control center for many functions of the nervous system, and endocrine, the hormone system. In terms of the menstrual cycle, it sends hormone pulses to the front of the pituitary gland. The pituitary gland sits just below the hypothalamus. It's called the master gland because it releases hormones into the bloodstream that regulate all of the other endocrine functions. So it regulates your thyroid, it regulates your adrenal glands. In response to these pulses of hormones, it secretes a hormone that acts on the ovary. So the ovary is really important to understand when we think about menopause. So persons with XX chromosomes typically have two ovaries, and they're depicted right here. Their main functions are to produce eggs and female hormones. The cyclic production of eggs and related hormone production regulates the growth and the shedding of the lining of the uterus. And the uterus is an inverted, pear-shaped muscular organ that functions to support a fertilized egg in pregnancy. The lining of the uterus, the endometrium, responds to cyclically released ovarian hormones. So the actors here that give individuals a regular cyclic monthly bleed, which we call a period or menses, are the hypothalamus, the pituitary, the ovary, and the uterus. So those are the four main actors here, and how they work and interact during the reproductive years changes when individuals go through menopause, and that's why individuals experience the changes that they feel in their bodies. So the menstrual cycle is a monthly series of changes the body goes through to prepare for pregnancy. Each month, one of the ovaries releases an egg, and if the egg isn't fertilized, the lining of the uterus, which we just learned is called the endometrium, sheds through the vagina. This is a menstrual period. What is a normal, meaning a typical menstrual cycle, so one that comes every month, is a predictable number of days, is a coordinated, synchronous bleeding and cessation of bleeding event. And it occurs that way, like clockwork for many people, because it's a highly regulated sequence of molecular, cellular, and vascular events. To get a menstrual cycle that's predictable from month to month, that isn't a problem, it requires a normal uterine lining and cavity and a very specific exposure and timed exposure of the uterine lining to hormones, estrogen and progesterone. And the way I describe this to patients is the uterus only does, and you'll see this in a slide coming up, I don't know where I put it, the uterus only does what the ovaries tell it to do. So, what is menopause? One menopause is a normal physiologic event, and it's recognized retrospectively after 12 months of no menstrual bleeding. Postmenopause is the time after this. And in the United States, the average age that a person goes through menopause is 51 and a half years. And if an individual ceases having menstrual cycles before the age of 40, that is defined as premature ovarian insufficiency. The menopause transition is the progressive endocrinologic decline in hormone levels that take a reproductive aged person from regular cyclic menses to their final menstrual period. So the perimenopause or menopausal transition is years before menopause is characterized by menstrual irregularities. So this is because there's an erratic nature of ovary function. So sometimes the ovaries are ovulating as predicted, and sometimes they're not. So this reflects this natural decline of estrogen produced by the ovaries. The average age is 47, but there's a wide range from 40 years to 58 years. And this perimenopause or menopausal transition period typically lasts 4 to 8 years. And it's longer in those that it begins earlier and those who use tobacco. So why do menses stop? And this is where I'm saying it is all about the ovaries. So I mentioned here that oocytes are eggs, and individuals born with two X chromosomes are born with 1 to 2 million oocytes. The sad thing to know is that 5 months of gestation, these fetuses have 6 to 7 million oocytes, so they already start declining before we're even born. And they decline as we age. So there's these individuals with two X chromosomes, generally defined as female, have 300,000 oocytes by puberty. And these are activated and regress during reproductive life with rapid regression in the late 30s and 40s. And menopause occurs when there are less than 1,000 oocytes remaining. So it's all about what's happening in the ovary because, as I gave you a snapshot of earlier, how does the uterus respond? What happens to menses? And it's that the lining of the uterus only does what the ovary tells it to do. The ovary is the boss, it's in charge. So, what happens is this very specific exposure and timed exposure of the uterine lining to hormones that I'd mentioned before is altered as these oocytes decline. So, during the menopausal transition, menstrual cycles become shorter, so there's less time between the start of one period and the start of the next period. There's more variation in length with it being less predictable. So some periods you'll have longer times between periods and some will be shorter. This means it's less predictable and more erratic. There are some menstrual cycles that are skipped in their entirety because an ovulatory event is skipped, and this results in missed periods with heavier and prolonged bleeding the next period, increasing episodes of more than 60 days without bleeding, and then bleeding eventually stops. Other symptoms, so our vasomotor symptoms, which we'll talk about later, hot flushes and night sweats, they affect 50% of women. They begin an average of 2 years before final menses. 85% will have them for a year, 25 to 50 for 5 years, and 15% for up to 15 years. And the average menopausal symptoms continue for many individuals for 7 years. So I always think of the song "It's Getting Hot in Here" and um, and relate that to vasomotor symptoms. And so I used this. This is from the Women's Health Network. I thought it was helpful. I'll show it in a couple of different ways. But this is an anatomy of a hot flash. So a hot flash isn't just being warm all the time or feeling like you need to be in less clothes than other people and something that you felt your entire life. It is a flash. So decreasing estrogens. So it's decreasing estrogen, or more correctly, it's the erratic levels of estrogen that the brain sees during the menopausal transition kind of breaks the thermostat. So if you think of this area that's the temperature sensor in the brain, it's a thermostat that's been treated nicely. It's gotten stable hormones for the entirety of its life course. And then all of a sudden, you have a rowdy teenager come through your house who presses all the buttons, turns the thermostat, turns it down, turns it up. It's seeing irregular, erratic things. And so then it's kind of broken. So this part of the brain in the hypothalamus then starts sensing that the body is too hot. So the brain sets a red alert to the heart and nervous system to release heat. And so the heart then pumps faster, so you might feel like your heart is racing and circulates more blood and activates the sweat glands. And that's a hot flash. And so skin temperature rises due to peripheral vasodilation. It's a sudden wave of heat with sweating. It lasts about 1 to 5 minutes, and then there are chills. And so I described this before I'd experienced my own set of very fantastic hot flashes. I'd experienced this actually when I was sitting across the table from one of my research assistants who was going through the menopausal transition, and she was wearing a V-neck shirt. And I clearly remembered this because I took it with me in terms of how I talk to patients clinically about these hot flashes. And she honestly looked like a mercury thermometer getting red from here up. And then she started sweating profusely. And so some people might actually never recognize the hot part of their hot flash, but they'll only recognize the cold sweats. So if people are only experiencing them in bed at night, they might only feel the cold sweat afterwards. So here's the anatomy of a hot flash. And I know I like showing it a couple different ways because I think this helps it make sense and helps you make sense of what's going on in your body. And so I've broken this down so you can actually see all the different slides here. So one, the part of the brain that controls the core body temperatures thinks you're too hot, even if you're not, and it begins the cool down process. Two, Your skin temperature rises and blood vessels open up to let blood flow increase along your skin in order to get rid of the extra heat. Your upper body starts to feel hot. You may feel uneasy or dizzy as your heart begins pumping your blood out faster to your blood vessels. Sweat glands prepare to perspire in order to get rid of that extra heat. Heat escapes out of the dilated blood vessels, and blood rushes across your face, chest, and neck, the flush, and you start to sweat. 2 to 5 minutes later, the flash is over, you're sweaty and damp, and your brain believes your core body temperature is normal again. That's the anatomy of a hot flash. And it's all because the erratic sensing of estrogen during the perimenopausal transition causes a malfunction in the area of the brain that regulates temperature. So why? Oh, sorry. So why? So I like this one. Come on, you have to have one more hot flash in you. That third step is still icy. And honest to goodness, when I was having a hot flash, I felt like I could have laid out in the 37 inches of snow we got up here in Rhode Island this winter and melted the driveway. The underlying pathology is not fully known. I kind of simplified it talking about the temperature sensor, but it's the area is the thermoregulatory nucleus of the hypothalamus. And so it's thought that women who have more severe hot flashes have a narrower regulation zone. And so it's due to first the irregular signals of estrogen and then the estrogen withdrawal of perimenopause. And so you might hear something about candy neurons. It's KNDY, not CANDY. But if you're listening to any podcasts, candy neurons are the ones that actually work to sense what's happening with the estrogen and regulate temperature. So this actually reinforces what Dr. Russo's earlier slides. Is it perimenopause, menopause, or something else? And so I'm really thrilled that more individuals are aware that menopause and perimenopause is a thing and are seeking care for it. But I think similar to attributing everything to VEDS, I think the pendulum is swinging a little bit the other way, that all the symptoms that individuals who could be in the perimenopausal or menopausal time period, or even premenopausal, honestly, are starting to attribute symptoms to hormones and the perimenopausal transition. And while I think it's helpful to make sure it's on the radar to consider it, I think individuals might not be seeking the clinical care they need. And I want you to stay curious with what other things could be causing these symptoms. I use an example of a patient I took care of who was sent to me by their primary care physician because they were experiencing a lot of joint pain, and they thought of everything else, and they thought, well, maybe it's menopause and the menopausal transition. And I spoke to her, and she was, of course, having also debilitating hot flashes. And I told her we definitely had treatments and hormone therapy would help with that. But the amount of discomfort she was feeling in her joints was definitely beyond what I'd expect with perimenopause and menopause, that the aches and pains of not sleeping well and aging, what she was experiencing was beyond that. She was a super active person and was rendered inactive. And because she continued seeing other clinicians and being curious about what was causing her pain, eventually she was diagnosed with a form of arthritis and got appropriate treatment. So now not only are her hot flashes better because she started taking hormone therapy, but she was properly diagnosed for the joint pain that she was having and treated as well. So other things for night sweats or hot flashes is making sure that your thyroid is okay, making sure that you don't have a bladder infection, making sure that your blood count is okay and you don't have a really high white count that can show some other problems with blood disorders. So making sure that you're thinking about other things and your clinician especially is thinking of other things that could be causing your symptom complex. So once your healthcare professional has helped determine that the menopausal transition is the culprit of these symptoms, there are options. I wanted to find a slide that said, do not despair. There are options out there. I wish there were tons of options, but as we mentioned at the beginning of this talk, and of course I'll come to at the end, um, the health of individuals born with two X chromosomes, generally referred to as females and women, has not been invested in with the dollars needed for federal research funding. And so while I'm thrilled that there's more and more interest in funding research on reproductive health issues in the menopausal transition, we're behind in terms of what we could be doing and what we could be offering if there were more information. So let's start with non-hormonal treatments. So the first non-hormonal treatment to talk about is cognitive behavioral therapy. So it's a guide of thinking through symptoms and working through symptoms that can help individuals manage their symptoms. And so what you can see here on the graph is a hot flash night sweat problem rating scale, and you can see the averages at baseline and at 6 and 26 weeks after randomization for group cognitive behavioral therapy and no treatment. And what you can see is that the symptoms were much improved in individuals, and the symptoms, the hot flashes and night sweat problem rating scale was much better in the individuals who received the cognitive behavioral therapy compared to the individuals who didn't receive anything. And one of the apps that individuals have proposed using for this is the CARIA app, CARIA, which can be helpful for cognitive behavioral therapy. Just going to make sure that's not anyone telling me you can't hear me. Nope. Okay, sorry. Another non-hormonal option is clinical hypnosis. And so there was a study here. You can see the solid line is just some structured attention from a clinician, and the dotted line is hypnosis. And the rating scale along the axis is average hot flash scores by weekly group uh, by week, by groups, sorry. And you can see in these 187 postmenopausal individuals reporting at least 50 hot flashes a week at baseline had a much reduced frequency of hot flashes. So 74% experienced a reduction in hot flash frequency compared to 17% who did not receive hypnosis. So small studies, but provides hope that there are some decent options that can be provided without medication. But there are also some effective non-hormonal medical therapies. So most individuals are familiar with selective serotonin reuptake inhibitors and serotonin and norepinephrine reuptake inhibitors, so SSRIs and SNRIs, as antidepressants, but they are also effective for hot flashes. Paroxetine, which goes by the brand name of Paxil, and sorry for the confusion, but in most medical talks we can't use brand names, but goes by the name of Paxil, 7.5 milligrams, which is lower than the dose used as an antidepressant per day, is FDA approved for hot flashes. Paroxetine, escitalopram, and venlafaxine are the best studied and all reduce the frequency and intensity of hot flashes. The side effects are dizziness, headaches, and nausea, and they reduce hot flash frequency by 50 to 60%. Another non-hormonal medication therapy is gabapentin, and so you may start with 100 milligrams 3 times a day and increase to 300 milligrams 3 times a day. One of the big side effects is dizziness and sedation, but where it can be useful is if an individual only really has nighttime symptoms, is taking 300 milligrams nightly, because if one of the side effects is feeling drowsy, and then it also helps with hot flashes, it can be a very effective non-hormonal medical therapy. And lastly, and I have I can finally say the name of this medication now that I talk to patients about it all the time, but fezolinetant is a neurokinin B antagonist. You probably, if you've turned on the television and seen any of the medication ads, are more familiar with its name of Veoza. So it was approved by the FDA in May of 2023. So fortunately, other options are coming on the market. And this targets that neuron that I told you about, the one with the fun name, the KNDy, KNDy neuron. And what happens is it increases the secretion of this agent, which is neurokinin B, which impacts the thermostat, the thermoregulatory system that's right next to it. And so this disrupts the problem of temperature control and the vasomotor symptoms. And so it's been shown to be more beneficial than placebo. And so you can see it's the 45 milligram dose in panel A. You can see a great reduction, 5.39 reduction in hot flash experience at 4 weeks and up to 6.44 at 12 weeks. And so a very big difference in the change in hot flashes and more than placebo. And the 30 milligrams and the 45 milligrams were very similar in terms of their effectiveness. So let's move on to hormone treatments. And so to give you just the briefest of brief history, if you're tuning in here because you're in your 40s or your 50s, the trial that really set menopause care back by decades was published in July of 2002. And so you're all probably familiar with the Women's Health Initiative. So it was halted in 2002. So most of you are probably in your late teens or mid to late 20s, early 30s when this was published. The reason I know exactly when it was published was because I was a second year, budding third year OBGYN resident at that time. And so the Women's Health Initiative was a massive randomized control trial where individuals were randomized to receive, and these individuals were mean age in their 60s. They were randomized to receive estrogen and progesterone if they had a uterus, or placebo. And the primary thing they were studying is whether or not starting hormone treatment decreased the risk of cardiovascular disease. So it wasn't looking at, is this an effective and safe enough treatment for hot flashes? It was in asymptomatic persons, does hormone therapy decrease the risk of morbidity and mortality associated with decreased hormones and aging? And so what they found in 2002 is that there was increased risk of cardiovascular disease. And so they stopped the trial because the trial was being done to see if it decreased cardiovascular disease, and it did not. And so it stopped. And the reason I clearly remember when this trial was published was all patients abruptly stopped taking their hormone therapy, and they were miserable because they precipitated acute and relentless hot flashes. So I think it's important to know, I don't know why this title came up like this, but estrogen therapy is the most effective treatment for vasomotor symptoms. So the treatment is estrogen alone if the individual no longer has a uterus, estrogen plus a progesterone or progestin if they have the uterus to decrease the risk of endometrial cancer. Indications, it's not for primary prevention of disease. So clearly found that in at least the ages that they studied, it wasn't good for primary prevention of disease. But yes, it's a great treatment for vasomotor symptoms, and it's a safe treatment for most individuals within 10 years of menopause who are less than age 60. But it's a very individualized discussion because every individual comes with a different risk benefit profile related to what exactly are the symptoms they're experiencing and what are their medical conditions that may increase their risk of the side effects and adverse effects of hormone therapy. So it's the most effective therapy for vasomotor symptoms. It prevents bone loss and fractures and treats genitourinary symptoms. When initiated soon after menopause, it may lower heart disease rates or prevent Alzheimer's disease. Breast cancer is elevated with estrogen plus progestin therapy if you use it more than 5 years, but that really amounts if you think about um, how much does it increase risk? It's less than one additional case per 1,000 users annually. And if an individual is only on estrogen because they don't have a uterus, it doesn't elevate the risk of breast cancer over 7 years. The other thing that's important is the only progestin studied with this risk profile is medroxyprogesterone acetate, and there might be other progestins available that might not increase the risk as much. We just don't know. So studies have shown that estrogen and progestin therapy, or estrogen therapy specifically, reduces symptoms by 75%. So who can't take it? So an individual who's having abnormal genital bleeding that we don't know what's causing it yet, a history of breast cancer, an estrogen-dependent neoplasia, active or prior venous thromboembolism, stroke, heart attack, known thrombophilias, liver dysfunction or disease, untreated high blood pressure, known or suspected pregnancy. And who should think about the individual risks a little more and really dive into them with their um, clinician is those with dementia, gallbladder disease, hypertriglyceridemia, hypothyroidism, fluid retention plus cardiac or renal dysfunction, elevated breast cancer risk, and hepatic hemangiomas. And it doesn't mean they shouldn't take it, it just means they should really engage in an active discussion with their clinicians. I put this up here, and it's a very busy slide, but it's to remind me of how and to show you how detailed this sort of risk stratification is. And so one of the things when I'm seeing a patient who is interested in talking about their personal risk and whether or not they're a candidate for hormone therapy is I use an online available calculator by the American Society of Cardiovascular Disease, the ASCVD. Calculator risk from the American Heart Association, where you plug in a whole bunch of information that includes an individual's age, body mass index, other medical problems, and determines whether or not they're high risk of a cardiovascular event in the next 10 years. And if they're low risk, an intermediate risk, they can clearly take hormone therapy. If they're high risk, it requires a very clear discussion. And then very high risk, we usually recommend against it. How long to continue it? It varies among individuals. Typically reevaluate after several years and consider a lower dose. Sometimes you'll stop and see how somebody's doing, but you don't have to discontinue at age 65. It requires an annual reconsideration of that individual person's risks and benefits. In terms of the estrogen options, there's many brands and formulations. There's synthetic estrogens, estradiol acetate, and 17-beta estradiol. FDA has approved both oral or transdermal options. Some side effects include breast tenderness, bloating, and uterine bleeding. And it can take 2 to 3 months for symptoms to stabilize. The risks, as mentioned already, is a risk of increased risk of cardiovascular disease, heart attack, stroke, and blood clot. With estrogen and progestin, it's increased risk of breast cancer as well. And so in terms of the progestin or progestogens and combination options, there's many brands and formulations. In terms of the progestogens, there's medroxyprogesterone acetate, sorry about the misspelling, norethindrone acetate, and micronized progesterone. And then combinations where you get both the estrogen and progestin together, which can be continuous, you take the same dose throughout the cycle, sequential, where you take a medication-free week, kind of like with combined hormonal contraceptives. And there are oral options and transdermal options. And it's important that any unscheduled bleeding after 6 months of use warrants investigation. Other thing to talk about is genitourinary syndrome of menopause. So this is a different constellation of symptoms that's super common, a common condition caused by lower estrogen levels affecting the vagina, the vulva, and the urinary tract. Some of the symptoms, what I often see is somebody who comes in thinking they have a urinary tract infection, and we've tested them a whole bunch of times and it's negative. So I say frequent urinary and tract infections. That's definitely one of the things, but it's also feeling like you always have a UTI, but you're never coming up as having a UTI. Pain with sex, itching or irritation, vaginal dryness. And it happens because the estrogen helps keeps tissues thick and elastic, and after menopause, they become thinner, drier, and more fragile. Non-hormonal options are lubricants and moisturizers. Hormonal options are low-dose vaginal estrogens, which are not absorbed systemically and can be applied as a cream, a tablet, or ring. And then some other options include DHEA or progesterone, ospemifene, and then there's a lot out there about laser therapy, but I'll say that it's controversial and not FDA approved, but it is often being offered by non-clinicians for this indication. So I'm going to turn it over to Dr. Russo to wrap us up.
Thanks. So that was really great. Thank you so much. I think it's important to understand the physiology of things to then be able to understand what the treatments are that we use. And so that's really helpful. And I think so taking all of this, we're just talking about this in general, but then how do we apply this information to people that have VEDS? Um, Disclosure that I am mostly an obstetrician and geneticist. I am a board certified gynecologist, but I don't do that in my everyday practice. So I'm calling my colleagues like Dr. Madison when I have somebody that has one of these conditions and they have really severe bleeding. I'll call Dr. Madison. I have other, and they help my friends that are gynecologists help me with trying to figure out on an individual basis, like what do we do for somebody that has VEDS and then they have, one of these symptoms or something going on. And really, the take home with this is that decisions and treatments should be individualized. And I would not say that estrogen and progesterone, because you have VEDS, is always contraindicated. I think it's really a discussion. Again, you saw everybody has their own medical issues, and sometimes there are other things where you cannot have an estrogen or progesterone. But it's sort of an individual decision making where you talk about benefits and risks. Um, and really, again, you want to use the lowest dose for the shortest amount of time always, but you want to have your symptoms also be treated. And progesterone, again, like when you think about the estrogen versus the progesterone, many people have used IUDs with progesterone. Again, that's not really systemic use of, or like when we say the word systemic, we mean something that the drug goes all through your body. But people use IUDs all the time for birth control or for bleeding. And I have not really yet seen any connection between the two. And just, I think the general gist of this is that we, as just need to keep pushing this needle forward, that this is an important topic and we do need more research. And finally, we are like people at UT are doing a hormonal study where they're trying to look at hormones across the lifespan. Um, but there's just not much that we know specifically about VEDS and these things. And so we're really having to just use our expert opinion at the moment. But that shouldn't, I think the pendulum has really swung where, you know, when I started all of this about 20, 25 years ago, we talked about you do not use hormones, you do like pregnancy bad, like hormones bad. We're really, that's not the case. And we've really come a long way to trying to better understand these things. And it's really always a risk benefit decision. And so that's what I have to say about that. Next slide.
Yeah, I think I was going to say here that what we know about menopause in all people, and then is what I've highlighted there in the red rectangle. I think what we might know about menopausal management in the VEDS population would be a sliver on the top of one of those ice caps, or it might not be present at all. And I know I mentioned this, but this is a call to action, right? Is that any of you have any ability to advocate? Less than 1% of global health research funding is allocated to women's health conditions beyond cancer. And that's why the state of affairs is what it is. But I am an eternal optimist. And so I'm hoping that you don't have to say, I'm just in the middle of menopause. Can I call you back in about 5 years? Because just the other week, Melinda French Hates donated $215 million to women's health with a focus on midlife health, which brings her total support to $600 million over the past 2 years. So I hope this is going to help people move so that they can have fabulous 40s, 50s, and above. So with that, I'll move to our last slide. And we thank you and we offer you good luck on your menopausal journey.
We're happy to, if you want to start putting questions into the chat.
I'm going to stop sharing so I can actually see anything other than my slides and my little rectangle. Uh-oh. Josephina, I think you might be muted.
Thank you. Thank you.
And I called you Josephina. Sorry, it's Josephine.
That's
Sorry
okay.
about that.
Thank you so much for your presentations. It was really very informative, and we've gotten multiple questions that I'll try to go through some of them today. Okay. And I think you've gone over this in the last few slides. But when considering a hormone replacement therapy, what hormone should be avoided at all costs versus some of the lesser risks? So you talked about estrogen might be one of the higher risk ones, but can you just, is there anything else that really they should, be careful about when you have VEDS?
I mean, I
I think
think,
one
go ahead, Kristen, go ahead.
I think one thing to consider when you're thinking about menopausal hormone therapy is the amount of hormone for menopausal hormone therapy is incredibly low and designed to mimic what the body would be making premenopause, which is very different than contraceptive hormone therapy. Not that that's truly contraindicated as well in many individuals with VEDS, but the dose is several magnitudes lower for hormone for hot flashes than it is for contraception. When you're thinking about the risk profile, I think Dr. Russo said that some people will have a total contraindication and that's individualized, but I don't think there's a blanket statement to put out there that any hormone should be avoided in all individuals all the time. I'll tell you the lowest risk formulation tends to be the transdermal preparations because it misses how the liver sees and acts on the hormone. And so transdermal application of estrogen has the lowest risk of cardiovascular disease and cardiovascular events. And then going on the lowest dose possible for symptoms. So the patches start at 0.025 milligrams. So starting with that. And then if after 4 weeks not feeling better, slowly escalating to 0.0375. And so being on the lowest dose needed. That would be my 2 cents about hormone therapy. And if you're really, really worried about hormone therapy, try some of the non-hormonal options because lots of patients get great relief with those options as well.
Great. Thank you. One person started low dose testosterone and progesterone for perimenopausal symptoms. Is there anything that they need to be aware of with VEDS using two hormones?
I didn't cover testosterone here because the data behind use of testosterone for perimenopausal and menopausal symptoms is not great for all individuals. And when I say not great, it doesn't mean that it says that testosterone is bad. It means that there isn't a lot there has been very little research in that area. So that's why I stuck to really talking about estrogen and progesterone. Um, so I don't know what the risk, particularly of testosterone in VEDS, would be, just because it's not something that I commonly prescribe for individuals without VEDS either.
Okay. Thank you. Um, So temperature control is a big issue, but I'm not sure what's a hot flash or other symptoms. Are there good ways to to provide temporary relief before starting a medical therapy? Any life hacks like cold on the neck or something for acute relief? And I think you talked about in the beginning of your talk some of the non-hormonal therapies that we can patients can go to, but maybe just a little brief update on that would be great.
Yeah, and I had a slide and I must have hidden it or deleted it, but there are some other lifestyle things people can try. And I'll tell them to you, and then I'll tell you how I feel about them now that I've experienced hot flashes and know how well they might have worked or didn't work. Um, but dressing in layers, so the second you start feeling like the heat's coming on, that you can take off a sweater and be more comfortable, keeping the room temperature cool, avoiding some of the dietary triggers. So sometimes really hot beverages and spicy food can do it. So those are a few of the different things. Having a fan blowing on you at night. One of the things, though, is don't make the bedroom so cold at night that you're chilly when you go to bed. Because if you're chilly when you go to bed, you'll pile on the blankets. And then if you, in the middle of the night, you'll end up with one of those hot flashes that ends up making you sweat through your clothes. In terms of those behavioral interventions, they can work for people who get their hot flashes during the daytime, but at the nighttime, it's kind of hard, right? Because you don't feel the hot flash coming on necessarily. You wake up because you're completely covered in sweat. But those are some things that people can try. Staying hydrated, avoiding spicy food, avoiding caffeine.
hmm hmm Okay, great. Thank you. So one question is, if you're taking estrogen in menopause with VEDS, would you, in theory, have similar risks about dislocating joints? Because she was told that during pregnancy. And what do you think about that?
Usually it's the estrogen's not doing that. It's there's a different hormone called relaxin. So I don't necessarily, I mean, you can chime in as well, Dr. Madison, but I don't think there's risks with joint laxity with this because there's other hormones in pregnancy that cause joint laxity, but it's not the ones that, oh, someone's saying, oh, it was a long time ago. She's like, it's all good.
Mhm. So here's another. Can you address the risks of estrogen patch with minimal history of a DVT? Is it an absolute contradiction?
So I so for all things, I'd say it's always a discussion of the risks and benefits in individualized treatment. Generally, an individual with a past blood clot, hormonal therapy is contraindicated. With that said, I always tell patients that they're in charge of their bodies. And so finding a clinician who's willing to engage with you about the risks and the benefits and talk to you about what your individualized risks and benefits are, potentially using the ASCVD calculator. And then sometimes, if it's an individual who, as a gynecologist, I think is too high risk for cardiovascular events and blood clots, I'll have them see their cardiologist or their hematologist who's managed their blood clots before and have them weigh in as well because they might have a different perspective to say, I think that blood clot was caused by something that I don't think is hormonally mediated. And I think in a short term, for this person who's debilitated with hot flashes, you might consider it. But in general, at face value, a history of blood clots is something that makes the hormone therapies contraindicated and makes insurances more likely to cover, like the fezolinetant, which you often need a prior authorization for. But if the physician writes on the prior authorization that this individual cannot take hormone therapy for their hot flashes because they have a history of blood clots, it makes it more likely that something like the fezolinetant will be covered, and it's something that is very effective as well.
Okay, great. We have a few gynecological questions. So, have you seen patients with VEDS that have a more delicate cervical lining? Patients that experience breakthrough bleeding, even on birth control pills that contain estrogen, progesterone, and progesterone only.
I'll say that breakthrough bleeding is super common on birth control pills for all individuals, VEDS, non-VEDS. The reason for that is that the commonly prescribed birth control pills that we use now in 2026 are very different than the ones that were developed back in the 60s. And the dominant hormone in all contemporary combined hormonal contraceptives is the progestin. And the way progestin works is it makes the lining of the uterus very, very thin. And so, what happens over time when individuals are on an estrogen and progestin containing combined hormonal contraceptive, and especially individuals who are trying to take the lowest dose of estrogen possible because the risks of estrogen, the lining gets very thin. So, some of the blood vessels sitting near the surface of the lining of the uterus, the lining of the endometrium, can be fragile, and those individuals have breakthrough bleeding. There's a lot of research going on right now with, oh my gosh, I can't remember who's doing it. Family Health International 360, looking at breakthrough bleeding and defining breakthrough bleeding and looking at contraceptive induced menstrual changes. So hopefully we'll have some things that might address it, but it's not just in VEDS, it's across the board that people experience this.
Mhm. Um, so there's another question. I think it's the opposite. With prescribed birth control to help heavy bleeding with VEDS, is that used as well for patients with VEDS?
So if somebody doesn't have a complete contraindication to being on hormone therapy because of their other medical conditions, combined hormonal contraceptive is one of the most commonly used treatments for heavy menstrual bleeding. It's been shown to decrease bleeding by anywhere by 35 to 50%, and it results in predictable menstrual bleeding. So it is a very effective option for heavy menstrual bleeding.
Okay,
I
and
should mention though that only one specific pill is FDA approved for that indication, but many are used off-label and based on their mechanism of action are likely all effective. They just haven't gone through the process to get that on their label.
okay, and they're asking if you have a specific experience with, I'm not sure if I can say this right, norethindrone estrogen, I guess, AS.
Norethindrone acetate,
Yeah,
Agestin. Yeah,
yes.
that's also a very effective treatment. So progestin only treatments like norethindrone acetate and medroxyprogesterone acetate are both also good options for heavy menstrual bleeding. The sad thing, though, about any of these conditions, and I tell this to patients all the time, that it's super sad that we're sitting here in 2026 and it's still trial and error. So I wish there were a way that I could look at the patient sitting in front of me and their different characteristics, their symptoms, their bleeding profile, and say, this is going to be a great option for you that's going to work with limited side effects. But where we are is that we have a menu of options, and for most patients, it's trial and error because one treatment that works great for one patient might not work great for the next patient. So, one of the most beneficial things that somebody with any gynecologic symptoms can do, because we don't have these mechanisms of personalized medicine, is to find a clinician who you feel comfortable kind of going on this journey with and that you don't give up, right? So if something doesn't work, don't chalk it up and say, oh, that person can't help me. They gave me something that didn't work. Understand that it's a trial and error process that your clinician also wished wasn't the case in 2026. You deserve better, but that's what we have in terms of the data available.
Okay, great. Maybe another two questions. These are on IUDs and VEDS. Um, and what is your opinion about using an IUD for abnormal uterine bleeding?
Do you want,
So,
Kristen, why don't you talk about that? And then do you want to also make sure you talk to them about how we talked about like putting them in under ultrasound guidance? Just that's what I
yeah,
recommended. Yeah.
yeah. So, the in terms of d decrease in bleeding, the levonorgestrel intrauterine system, which most of you probably better know as Mirena, is very effective at decreasing bleeding and decreases bleeding by up to 97%. So it's an incredibly effective option. One thing for patients to know is that in the first 3 months of use, and then sometimes up for the first 6 months of use, you can experience very irregular bleeding as the lining of the uterus gets used to the fact that there's a progesterone releasing device in there thinning the lining. And so if you're okay having irregular bleeding for about 6 months, which then might lead to very light periods or no bleeding at all, then it might be a really good option for you. And I also let patients or individuals know that it's not unsafe to not have a menstrual period when you have something like the Mirena IUD in place. The way it works is it makes that lining that we talked about earlier very, very thin, so there isn't a lining to shed. So it's not like something old is building up in there that needs to be released or something's being held back. It's just that it isn't growing while the IUD is there. So there isn't anything to shed. But as immediately after it's pulled out, the lining starts growing back, and then individuals can get back to having their periods. There isn't a lot of data to support this, but our expert opinion is that among individuals with VEDS, an IUD can be inserted under ultrasound guidance. It's pretty easy to do that in the office, where you coordinate it with your ultrasound department, where they put the ultrasound probe on the abdomen and they can physically watch the IUD getting inserted so you can ensure that it stops just before the top of the uterus and is inserted in exactly the right position. Um, Other things to know is that some places do offer pain management options for IUD insertion that can include taking um, taking medication before you come in if it's safe for you to take non-steroidal anti-inflammatories around the clock for a couple of days beforehand before the IUD insertion, using a lidocaine jelly that gets placed and sits in the vagina for about 15 minutes before attempting the IUD insertion, using a block where a needle is used to inject numbing medicine into the cervix. And then some places, I think Planned Parenthood does offer IUD insertions under sedation, which is still done as an outpatient procedure. And for some individuals, I will do it under anesthesia in the operating room. But with all of those, I do it under ultrasound guidance, just so I can be absolutely sure that it is not going beyond the top of the uterus where it belongs.
Yep.
Mhm.
Because
And
that's the biggest risk. So the biggest risk for anyone getting these put in is uterine perforation. So Dr. Madison talked about how when they put it in, if it pokes a hole through the uterus and it goes somewhere else, that risk is about 1 in 1,000. And historically, people are like, oh, well, the uterus is going to have weaker tissue with VEDS, and so they're probably at a higher risk for perforation. That has not necessarily shown. Anecdotally, we don't have the data right now, okay, but I talk to lots and lots of people. I know people that have VEDS and have these, and I have not heard a lot more of people getting perforations. The study needs to be done, of course. So
I, I I think she's,
I think she's frozen.
I
Yeah,
think
there's
she's
no there's
frozen.
no evidence showing that there's an increased risk of perforation, but just because of how VEDS works, it's a low addition. It's not difficult to add an ultrasound to the IUD insertion. But with that said, if you use the typical practices for IUD insertion and go to an individual who is skilled at IUD insertions, you would probably be fine without using ultrasound guidance.
Hmm. And is there any indication that because they have a connective tissue that the IUDs could move, or is there any issue that with that?
There is no data that IUDs out migrate up and out, I guess is the way to think about it, migrate up and out of the uterus after they're placed intrauterine. It's when they migrate is when they're poked through the wall of the uterus and then they continue working their way out. Um, Expulsion of an IUD, there's about a 3% risk in all people that the IUD might expel, meaning the uterus will cramp it out and it will come out of the cervix and the vagina. There's no data to support that risk is increased among individuals with VEDS.
Okay, great. One last question. How do you address heavy bleeding with VEDS, but with a history of many pulmonary embolisms?
Yeah, that is a tricky issue because a history of blood clot means that hormonal therapy is contraindicated. Um, in an individual with VEDS and a history of multiple pulmonary embolism, that would be a discussion with between the hematologist and the gynecologist. For many of those patients, a levonorgestrel IUD can be a good option to treat the heavy bleeding that won't necessarily increase the risk of blood clot and stroke because, as we mentioned already, it just exerts its impact on the lining of the uterus, not in the entire body. But for somebody who's that complicated, with VEDS or without VEDS, I'd have a conversation with that individual's hematologist because complicated patients require team-based care to get the best outcomes.
Okay. One more question that I'm just going to ask, and we have a few questions that can't be answered right now. Um, is certain hormone replacement medications that can kickstart menopause or delay menopause?
I don't know if I understand that question.
I guess they're asking whether there are, if you go on hormone replacement, would it start menopause or could it delay menopause? But you usually probably wouldn't go on hormone replacement until after you go into menopause.
It won't impact. So menopause is a physiologic process that your body is going to go through. And so it's not going to impact your physiologic process. It might impact the symptoms that you're having and make it harder to diagnose. If you start it when you're perimenopausal, it might make it harder to diagnose when you're menopausal because you won't have the symptoms of menopause and you might continue having cyclic bleeding, but it's
Right.
not going to change what's happening with your body. It just might make it harder to diagnose it.
Right.
But if you're feeling well and it's safe for you to be on hormones, I don't know that it's important that you know the exact age that you go through menopause. Entirely. One of the things it's really hard to tell when people are going through menopause when they have a Mirena IUD or a levonorgestrel IUD because it causes a lack of periods. And so I just listen to what symptoms the individual's having.
Mm. Right. Yeah, that makes sense. All right. Well, thank you so much for everyone who submitted questions, and to you, Dr. Madison and Dr. Russo, for giving your expertise and insights. If we weren't able to get to your question today, there's staff in the Marfan Foundation's Help and Resource Center can assist with questions and your specific situation. So please visit marfan.org/ask, and a member of our team will be in touch. So thank you again to our speakers, Dr. Russo and Dr. Madison, and to all of you for taking the time to join us today. Please take care and enjoy the rest of your conference. Thanks so much.